Ibrahim, Abubakar, or whoever across the country, just to make sure, Kemini, we get the content and look at the issues for duty bearers to also solve.
Oh, absolutely. And listen, we've had stories from across the country on the state of health facilities all over the country, from CHIPS compound to regional hospitals to referral hospitals. We've seen them all, and today we'll show you each and every one of them as we have a conversation on the back of that. You also meet our guests pretty shortly, but let's link to that video from Godwin.
My journey began with a daunting challenge, traveling from Nawuni to Singa and Tamale, involving a crossing over the White Volta. Without life jackets available, I had to navigate the river just like the locals. What if resounded in my mind throughout the canoe ride. Despite the smooth waters, it was a deeply unsettling experience for me. On the other side of the river, I observed people arriving, their feet caked in mud, clearly exhausted. They warned me about the challenging road network ahead, but my determination to reach Singa held firm. And so, my journey continued from there, aboard a tricycle. About 10 minutes into the journey, the rugged nature of the road caused my stomach to churn uncountably. It was a harrowing, frightening, and perilous ride. It took us about 2 hours to reach Singa, a community in the Kumbungu district of the northern region. The community's poor roads severely hinder healthcare access, leaving residents deprived. The Singa Clinic, the only health center here, is inadequate for providing health care to the sick. Upon arrival, I found patients already admitted at the detention room. With a shortage of equipment at the health center, nurses were forced to improvise to provide care. The facility has been leaking whenever it rains for days.
It's supposed to be our dispenser. And because of we lack so many things here, that's why we converted it here to be our where we can put our fooders and then other things here. And you can see this fridge too. We're supposed to have a proper fridge where we can even have thermometer, tell me the temperature of the fridge here. And then as you can see, we have vaccines here. And then sometimes we have to remove some of this ice pack here, put it here, and then collect all the vaccines here, just to manage the temperature. Just to preserve them. It's not the right way, but we are just managing here.
Sustainable Development Goal 3 emphasizes good health and well-being, aiming to ensure healthy lives and promote well-being for all at every stage of life.
For all cancer patients, about 60% of them will require radiotherapy at a point in time of the management of their cancer. So radiotherapy is a very important aspect of the management.
According to the National Cancer Institute, radiotherapy is a cancer treatment that uses high doses of radiation to kill cancer cells and shrink tumors. Ghana has about 2 of such machines, one at the Kolebu Teaching Hospital in Accra and the other at the Komfanochi Teaching Hospital in Kumasi. One private healthcare facility also has the machine, but the challenge is the machines at both Komfanochi and Kolebu frequently breaking down, leaving many cancer patients stranded.
They are to pay 13,650 at Kolebu. But as it stands now, I can't even do it at Kolebu. I'm doing it at Sweden, Ghana, possibly, if I get that fund. And Sweden, Ghana is charging me 37,500 cedis, which is 3 times what I would have paid at Kolebu if the system was working.
Treating cancer is like killing a snake. Once you initiate the action, go and make sure you kill it. Now, if you don't kill it and it gets back to bite you, it bites you with a lot of venom. You are receiving referral. Once you initiate the action, go and make sure you kill it. Now, if you don't kill it and it gets back to bite you, it bites you with a lot of venom. You are receiving referrals from 12 of the 16 regions of the country. And this is the only radiotherapy center in the northern sector of the country. So it's like every 10 million people have access to one machine. When the International Atomic Energy Agency feels that every million people should have access to one treatment machine.
Bodies, once again, are piled on the filthy bare floors, covered in flies. The dilapidated conditions have only worsened, with water droplets from decomposing bodies pooling on the ground, unable to drain due to clogged and poorly maintained channels. The drains, now more choked with filth than ever, are breeding grounds for maggots and other vermin. Despite the public outcry and promises of reform after my first visit here, the situation has deteriorated even further, turning an already grim scenario into a ticking time bomb of public health. The storage rooms, already overcrowded during my last visit, are now beyond capacity. Bodies are decomposing at a rapid rate, creating a hazardous environment not only for the mortuary staff, but also for the surrounding community.
Well, you look at that content by Godwin Asedeba, it also brings into focus and perspective the current state of facilities across the health sector, and that also means that we have to put more focus on the subject as well. And Kamani and I quickly will have to go through the marshaled guests we have this morning across all forms of organizations and spectrum when it comes to healthcare and management right here in Ghana. And so straight away, I'll just have to start from my end, and I have here first seated, just also across me, I have to say my extreme left is Perpetual Ofori Ampofo, and Mrs. Perpetual Ofori Ampofo is also the president of the Ghana Registered Nurses and Midwives Association. Indeed, before the start of this, emphasized that, well, we like making the mistake calling them midwifery instead of midwives. And good morning to you. How are you? You're a regular on TV3 as well as 3FM and across Media General because of Daniel Opoku, our lead Labour correspondent, who is always featuring you. Yeah. And then also Dr. Nawani goes by the first name Mark, has a middle name as well. What's your middle name?
Kate.
Kate.
Yes.
And, well, it's good that we've brought you here because you're coming from the Committee on Health in Parliament.
Yes.
And you're also a member of Parliament. Which constituency?
I represent the good people of Nabdam.
Nabdam.
Yes.
Okay, so it means that this one, particularly looking at the demography of the constituency, also falls into sharp focus.
Exactly.
Oh, okay.
Exactly.
And then also making sure that he's able to help us right here is the acting registrar for HEFRA. And Dr. Winfred Ba is here. That's the Health Facilities Regulatory Authority. Dr. Ba is here. Dr. Ba, you're in blue as me.
Yes.
We love blue, right?
Yes, we do.
But these are very thorny, sensitive, but important issues we're talking today.
Sure, sure.
Well, Kamini, can you do introduction of your guests as well? And then we'll come ask them one or two other questions in relation to the story that was put together by Godwin Asedeba.
Absolutely. On this end, I have to my immediate left, Dr. Senano Kwesi Jokoto, who is the Deputy CEO of the National Health Insurance Authority. Next to him is Dr. Wallace Odiko Olenu, who is Acting Program Manager, Non-Communicable Diseases Control Program at the Ghana Health Service. And then behind him also is Echo Beckles. Echo Beckles is a representative from the Health Service where the insert we just played, that documentary on our mortuaries. But before we even look at that, talk to us about how critical it is to take a look at our state, or the state of our health. The insert we just played, that documentary on our mortuaries. But before we even look at that, talk to us about how critical it is to take a look at our state, or the state of our health facilities.
Thank you very much. And I think this is a very good opportunity for us to highlight some of the gaps within the health delivery system in Ghana. But before we get there, obviously it's always good to talk about the progress that we have made.
Well, Doc, I apologize. It would appear that your microphone is off at this time, but you'll fix that. Then we learn what your thoughts are about this event quickly.
So thank you very much once again. And let me applaud Media General for
3FM 92.7.
It would help us to look at the gaps within the health sector, health delivery system. But before we get there, we also have to acknowledge that some progress has been made over the years. So firstly, our life expectancy has improved over the past 3 decades. We have also seen a decline in maternal and child health mortality. And we've also seen very good vaccines.
Indeed. Doc, I know you have a lot of important things to say. Unfortunately, the microphone won't let us hear you. So what we'll do is we'll hand over to Roland, and then he takes on the conversation. Roland, you come back to us, and then we have ours too.
Well, certainly. And first we'll then have to get to Dr. Ban here. And you're not new to health practice, health facilities, and the state of infrastructure. Indeed, all of you are not. But you take the cognizance fact of that content by Godwin Asedeba in relation to what the vexed matters are. You have to say that we could do better. Why do we have the facilities in the state in which they are?
Well, thank you very much. And I think I also want to applaud TV3 and Media General for putting this together. This is an important conversation. And in the heart of excellence is data. I think that what we want to do today is very important. We need to look at the situation, the way it is, and then look at how we can put things together to make sure that our health delivery in Ghana is better. So I think there are challenges. Some are resource. We have financial challenges, we have human resource challenges, infrastructure challenges. I think, like he said, we've made some progress, but we are still not there. Somebody said that in the modern Ghana, our hospitals or health facilities should be like hotels, where people come, you sleep, you have peace of mind, and they're tired instead of going to rest. In the same way, when you get to the hospital, the environment must be nice. You must also get good quality service. And I think that is where we are getting to for going to rest. In the same way, when you get to the hospital, the environment must be nice. You must also get good quality service. And I think that is where we are getting to. For me, this discussion should be able to get us to that level where we can get our health facilities to be up to date and our health quality systems up to the level we all want it.
Then that transitions are, because we'll come back to the practitioners there, because they then tend to face the drudgeries of having poor infrastructure. You tend to go around very often, and in the course of our work, we go with you. You visit the facilities, but the concern is that we elect you into parliament. Some of you even become ministers. You even get to serve on the committee, and rightfully you're here because of the committee. And you know that the situation is bad, because you're not only somebody who is on the committee, you're also a member of parliament. Sometimes some of you even become MPs, and then you become the health ministers. If you look at the facilities as they are, why is it that when we do the allocations in the annual budget, we don't ensure as committees that the rehabilitation of the facilities are done?
Let me say good morning to the viewers of TV3 and say that I've been practicing practically the whole period of this fourth constitution. I mean, this period.
In this fourth republic?
Yes.
You've been practicing as a professional?
Medical doctor, okay. Yes, since 1993. And I've seen the genesis or the changes that have gone on over the years. Indeed, funding of our healthcare system is what is at stake. We have an increasing population. We are becoming a lower middle income country. So there's lifestyle changes. And so we are also, and we're being able to diagnose certain disease better than before. And so the cost of healthcare continue to balloon since we can now take care of those diseases. We have positioned ourselves in such a way that we are looking at ways and means that the healthcare system can get. We have positioned ourselves in such a way that we are looking at ways and means that the healthcare system can get more money to manage the healthcare, to push the system to create more resources and use the resources to improve conditions in the hospital, to push the system to create more resources and use the resources to improve conditions in the hospital, use resources to motivate staff to stay at wherever they find themselves, because that is the main problem that we have now. How to motivate staff to stay wherever they want to stay, they have to stay, and how to improve the conditions in terms of maintenance of the infrastructure. And to be able to do that, we need more resources. Currently, we're doing 9%.
By way of the allocation?
No, Abuja declaration.
Yes. Says 15%.
15%.
And you guys fall short.
Yes, we fall short of even the 15%.
Even though you meet the WHO standard of in excess of the 6.
We are near it, but the issue is that we fall short, and we don't have enough resources to take care of the patients. And so what do we do to get this gap? First and foremost, we need to fill the gap. And then we can now meet the standards that have been set. Let us just remember that the universal health coverage targets, that's 2030, is just at the corner. And so we need to do something special to ensure that we're able to meet those targets. And those targets, we have to try and meet them and be with the civilized world, should I say so.
Well, we'll come back and then talk about this more, because we have a framework, right? And that framework also means that Ghana, we also have our own target set. We're making the effort. But the question coming in will be, are we too slow in setting those same goals and trying to achieve them? But we'll see how that goes, Kamini.
Indeed, first, Roland, let's pick initial thoughts from my guest here on the documentary we have shown already. And just a quick reintroduction of my guest. To my very far left is Dr. Wallace Odiko Olenu. He's with the Ghana Health Service, and he's the Acting Program Manager, Non-Communicable Disease Control Program. To my immediate left is Bright Emisa Nyako, who is with NGOs in Health. Gentlemen, again, thank you so much for joining us on this national forum on the state of our health facilities. Now, because the conversation has already started on the documentary, let me pick your initial thoughts on what we have shown so far about the state of our mortuaries. I'll start with you, Dr. Olenu.
Yes, very good morning to you all. And I really I'm very impressed with your decision to have this conversation at this very critical point. It's very, very important that we have this discussion. I want us to realize that health infrastructure is a human rights issue, and it's a national development issue as well, because we cannot achieve universal health coverage, as the previous speaker said, and our SDG Goal 3 without providing equitable and then safe quality healthcare to our populace. So it's very important that we ensure that all policies that are geared towards ensuring that we provide all these services to our clients, our populace, is very, very important. And we should also remember that infrastructure doesn't necessarily mean only the physical buildings. We also have to remember that it involves the policies and the systems that run the institutions. So when all those systems are in place, then the infrastructure can be said to be complete. So I'm looking forward to very fruitful discussions, identification of the gaps, and then most importantly, how to chart the way forward. Future, we'll look at how we can improve the state of our health facilities. Thank you.
Indeed, and that's why we are having this forum to look for better ways to handle our health facilities. But Bright, I come to you now. One thing that is assured for all of us is death. Looking at the state of the mortuaries, how does it make you feel that perhaps this could be the end point for you or your relative or anybody you love so much?
Thank you very much, and a very good morning to the panelists and your audience, TV3 and 3FM and the others. I'm also grateful we are here to contribute our bit to this discussion of the National Health Forum. You would agree with me that if we look at the videos that you showed concerning the state of the morgues, you get devastated as a human being. This is your end result, and that is where you would be going to. If you happen to live in a very hospitable condition, and then you see some of these videos showing, then what comes to mind is you think of, is it possible to even design your own morgue in your house, which is largely impossible. So it means that we all need to think through and then look at how we end our life and then where it gives us peace moving forward. Everybody in one way or the other might go through this system before you are declared where you are supposed to go, whether heaven or where. And I think you believe in a peaceful environment gives you a very peaceful rest. And that is what we should be thinking of to at least begin to warm our souls and then drive home safely to meet our Creator, the Almighty. So it is actually not in the best of situation or state, and then we need to do something about it. I believe this forum will present some recommendations moving forward. Thank you.
Indeed. Thank you so much, Brighton, Dr. Oleno. And indeed, it's not only about the morgues. In fact, where you will be before you get to the morgue is also a very big problem, which is why we are going back to Roland and his team of panelists on the other side, where the discussions will begin proper on, the state of our hospitals across the country. Roland.
Well, we need to preface this, have a comprehensive outlook on the subject. And Eric will be joining me, and we're talking about Maui now, the popular name, Egbeta. And, well, it also means that we have to show you what really the pictures are in terms of just, citing some few instances of poor health facilities. Because these facilities are where we have our health workers working. And you know that within the whole ecosystem and the environment of working, where you work is very important. It has a psychological effect on how effectively you are able to work. And it's very important that we do that. And so Eric Mawinaibeta is ready.
FM 92.7.
And you're welcome here on TV3. We're having that conversation, all-important conversation on the country's health infrastructure, the systems, and essentially seeking to, amongst many other things, find solutions from all of the experts who are gathered here this morning. What we want to do for you is to set the base, the foundation as to what really is available when we talk of Ghana's health infrastructure, from systems, equipment, to personnel as well, and their level of training in all of the things that we will be having a conversation on just briefly. And so what I want to do for you, just quickly, my task is quite simple, is to set that foundational base, and then the conversations can proceed. And so the latest is what we have on the screen right now, the health facility facility assessment conducted in the year 2022. And this is what was discovered after that work was done. A total of 9,505 total facilities we have in the country as of the year 2022, with the public institutions constituting 7,745, and then the private as well, 1,360. I'll break that down for you, and then you get to see quickly as well a much clearer picture as to where it all is and what more it is that we need to do. When it comes to all of these facilities, the 9,505, and the ability to provide antenatal care, we know that 85% of these facilities are able to do that for us as at 2022, with 67% of them being able to deliver antenatal care 24/7. Now, when it comes to surgical services, we know that 66% of these facilities can perform some surgical services in one way or the other. And then when we talk of bellwether, which goes a bit more intrinsic when it comes to surgical delivery, just 3% of these facilities, these 9,505 facilities, are able to do that. On matters of emergency care as well, there's 66% of these facilities which are able to offer some form of emergency care as well, and also very important, when it comes to full emergency, basic emergency and obstetric newborn care, 15% of them are able to do that. But let me just try and expand for you the 9,505 facilities we have in the country. Like I mentioned, 7,000 plus of them are public institutions, 1,360 are private, and then we know that in health delivery, the missions and then the Christian Health Association as well are pivotal in all of that, and that as well, 295. On the classification of our health services, based on this report, we know that 420 of these facilities are classified as tertiary, then 190 are classified within the regional status, 3,540 are district health centers, we know 3,355. Then the CHIPS compound, which is the basic, really, when it comes to Ghana's healthcare delivery service. CHIPS compound are believed to be the basics where persons can get quick emergency services as and when it matters most, particularly found in rural areas, amongst many other things. Let's proceed and then begin to break it down for you on service delivery as well this morning, as we continue to lay the foundation for the conversations expected this morning. Like I mentioned, 85% of these services or these facilities are able to provide some form of antenatal care or service to pregnant mothers. And if we move on to from antenatal care to deliveries, 71% of them are able to do that, which is quite great on the base value, and then 67% of them are able to provide this service 24/7. When it comes to matters of immunization, which is very important as well, we know that 85% of these facilities can provide some immunization for children. When it comes between the ages of 1 to 5, where more often than not the 6 killer diseases are often mentioned, we know that 69% of these facilities provide this level of care. Family planning, also very important. The important analysis and facts which were gathered from this 2022 assessment is that 97% of the facilities, over 9,000 facilities we have in the country, are able to provide some form of family planning services as well. We just want to move on quickly to staffing and then training services as well. Of all of the facilities which were surveyed and work done on them, we know that 58% of staff in a number of these facilities had received some form of training in providing antenatal care. When it comes to training for taking care of newborns as well, 45% of them have received that. Immunization and matters relating to child health safety as well. We know that 29% of the staff in these hospitals had received some level of training at least 2 years prior to the conduction of this survey. And then specialist care hovering around 57% of that. Let's look at facilities and infrastructure readily available. Isolation beds, what we found out from this 2022 survey conducted is that 38% of these facilities have some form of isolation facilities as well. Oxygen supply on the high side as well, 81%. But on the CHIPS compound level, averagely, that's quite on the low side as well. When it comes to transportation services, emergency, we know ambulances being able to transport patients when it comes to emergency services, amongst many other things. On the average, there is a not so great number of 48% emergency service availability in being able to transport these persons as and when they need it. Resuscitation, just 45% of the facilities have immediate facilities available. Now, lastly, what I want to provide details on is when it comes to budgetary plan for these hospitals to run biannually, just a paltry 23% of them had prepared annual budgets by which they were operating by. And if you read the report extensively, there are recommendations as to what must be done to improve this greatly. Also, annual audits of these health facilities, the 9,500 health facilities, 55% of them receive some external audits amongst many other things. This is where it gets interesting. Of all of the health facilities which were surveyed in this report, 99% of them receive or take some form of fees at their outpatient department. And so a case of concern, because we know that the health insurance is expected to be working and is supposed to take care of some of these matters. And so it will be interesting to find out why we have as much as 99% of these facilities receiving some sort of fees. But when it comes to written guidelines in announcing to the person seeking care that we receive this amount or you pay this amount when you come to our OPDs, just 6% of these facilities had that outlined. And so that's just by way of quick data for you where we are. And then I can cede the floor to both Roland and Kamini now to properly begin the conversations.
Three FM 92.7. 3 FM 92.7.
And that's where we situate the conversation rightly. And I have to say that, well, we had Dr. Senanu Jokoto also right here, just do a bit part introduction, also joining me on the side of the divide. He rightfully, as a Deputy Chief Executive for the National Health Insurance Authority, also means that he becomes part of the whole conversation, because patient care, funding, and that rightful and important healthcare delivery, it's something all of us should be concerned about. But all the people who keep bearing the brunt, apart from the patient, will have to be the professionals. And I know that Madam Perpetual Ampofu also tends to represent them on the union side. But you take a look at the facilities that your workers, your professionals operate in, and I made an assumption earlier, or an observation, which is if your environment where you work is actually bad, it has a psychological effect on you negatively. And you're watching the statistics, watching the pictures, and what you already know, it's that bad, is that not it?
Thank you very much, and congratulations to Media Journal for initiating this conversation. In fact, it's been something we've been talking about for a very long time, and it's something we cannot stop talking about. So there's a good platform for us to continue the discussions. And indeed, We are nurses and midwives, we are doctors, we are pharmacists, allied health professionals, all working within the same space. And based on the figures you showed, if you look at the whole of Ghana, we are looking at over 9,500 health facilities with over 7,700 within the public health sector and the rest within the private health sector. When you take the health facilities, when you move away from the capitals, from the regions, go to the districts, and then move lower down to the health centers and CHIP compounds, these facilities are actually not in the best of shapes. Even with, for those, some of those facilities within our capitals, if you take even the regional hospitals and the teaching hospitals, it is not in the best of shape. You talk about the infrastructure, the equipment we work with, the drainage systems, the toilets, the disposal of refuse, and all those things are not in the best way that will actually help the health professional feel good in working in these environments. You mentioned earlier, or he mentioned earlier, the acting registrar of HEFRA, that when you enter a hospital, you should feel like you've entered a hotel. We are nowhere near
as if
that.
in your bedroom.
Exactly.
Well, there are some few facilities, or maybe at least one.
Yes, UGMC is in a good shape. And
UGMC is a hotel, actually.
It's in a good shape. Why can't all our hospitals be like UGMC? Why can't they be? And it goes back to the issue of resources. And mind you, the Abuja Declaration, which was signed on by all African heads of states, goes as far back as 2001. So it's 24 years on. And where are we? We are talking about 9% of the national budget committed to health.
Yeah.
So successive governments have not done much when it comes to actually making resources available for the health sector. And indeed, there was a time in our country where there was GOG, you know, government funding for health facilities. It stopped, and as we speak now, all our health facilities rely on internally generated funds.
IGFs?
IGF, exactly. That is why when he was showing the stats, you saw that OPD services up to about 99% needs to be paid for. So when you don't have the requisite resources, you cannot innovate, you cannot build on, and that is where we find ourselves.
We have quite lengthy time to do this conversation up to about 11:30 and thereof. And I know quite well, apart from you making the effort to play in the policy space, into politics, you also managed the Ghana Health Service for the Volta region. It also means that you're clearly doing public health administration apart from the combination for practice clinically. And I have to say, I have common examples of my own experiences where I have friends who move from, let's say, it could be the Tema General Hospital or one of those general hospitals we have around, and the next 3 months they move into some NHS hospital and they tell you, a difference not there, and you will find that they bear testimony to the fact that the facilities that are in the West or in the advanced country seem to be orderly managed, and there seems to be a correlation between maintenance, funding, and then caring for the psychology as well as the environment of the health worker. How do you think we can get there, knowing what you know clinically and then administratively? Dr. Jogoto.
Thank you very much for the opportunity. And once again, let me thank TV3 and Media Journal for this opportunity to engage in this very important discussion. So you have hit the nail right on its head. I think you've started you've started giving us the solutions to this very complex issue. Funding, sustainable and reliable funding. Yes, we all agree that health infrastructure is the backbone of service delivery. So if you look at the WHO Health Systems Framework, which is built on 6 core building blocks, service delivery is one of them. But in service delivery, like I've mentioned, is health infrastructure. health infrastructure actually cuts across all the building blocks that we are talking about. And Honorable Mark Mewani has already spoken about the health workforce and the influence of health infrastructure. We can also talk about health information systems. We can also talk about essential medicines, vaccines, and technology. All this would require some very good health infrastructure. But to even get there, you have to look at the kind of funding mechanism that you have in place. That is the backbone of the kind of health infrastructure that we would have. I think we've already talked about the funding shortfalls. The Abuja declaration is supposed to be 15%, but Ghana is doing between 6 to 8%, depending on which year you're looking at. The GOG support over years has not been very consistent. So if you look at the local funding mechanism, basically it relies on budget allocation from government and then the National Health Insurance Authority. And what systems do we have in addition to ensure that we have regular funding, a revolving fund for maintenance of these equipment and infrastructure?
That's very important. Why?
What kind of funding do we have for it? So I've been in the public health space, like you said, for close to 2 decades now. If you go to most of the facilities, they do not have any revolving fund available for maintenance of facilities and maintenance of these equipment. So we've seen a lot of brilliant, beautiful facilities coming up across this country. Ridge is one good example, is one of the greatest facilities that you can see. UGMC you've talked about. You can go, we can talk about a lot of regional hospitals. WA Regional Hospital is relatively new. Upper East Regional all came up during the first administration of His Excellency John Dramani Mahama. You can talk about a lot of these district hospitals. But a few years down the line, when you go there, what do you see? So 3 weeks ago, the health minister did something that was very important.
Which is what?
He went to the Ridge Hospital and he highlighted some of these deficiencies. The CT scan, MRI not working, the washrooms not in really good shape. He went to Tamale, he highlighted all these. It's very important because this is the beginning of the conversation. I'm sure that may have even triggered this particular conversation. What can we do? So first of all, from where we sit as National Health Insurance Authority, we have to make sure that we pay realistic tariffs. Yes, most of these public facilities have internally generated funding, but majority of the funding that they have to run their hospitals is from NHIA reimbursements. So anytime there's a shortfall in that, then they run into difficulties maintaining infrastructure and equipment because there's nothing in place. So if we pay realistic tariffs, we do regular reimbursements, then they are going to have access to more funding, like the Honorable Member of Parliament said a few minutes ago. And when they have this regular funding, then they can actually plan for it.
Dr. Jushba, what's your point with the fund? Are you saying that we have to pay more on whose side?
So we have to have realistic tariffs, and I can tell you, so I'm landing there now. His Excellency, the President, realized this gap. The NHIL has been capped for the past few years. When we say has been capped, that means the funding available for NHIA to reimburse these health facilities has a limit has been placed on it. So whatever we collect from from taxes that is supposed to go to NHIL for the health facilities would have been capped. So maybe you're supposed to get 100% of it, you are given 40%. I think that's the Act 947, I believe.
It has been capped And
what's the percentage of the capping?
The capping is
of the annual collection?
85.
85.
Yes.
So what goes
15% capping.
15% capping.
Capping, yes.
So 15% goes into the consolidated fund,
yes.
although only 85 goes to the National Health Insurance Authority.
Yes, yes.
Okay.
No,
I
think that's the other way around.
That's the other way around.
Is it more?
It's not the other way around. It started with about 66, but over the years
it's been increased.
So annually we've seen
good. So you see
an
that
incremental reduction, so to speak.
Yes. So you see that shortfall. So
but the 50% is a very big figure.
I understand because of the volumes we're talking about. The
billions of cities. So last year, 4 billion was available to NHIA, and then this year it is projected that 10 billion would be available just by the commitment of the president to uncap the NHIL.
How does that solve the matter we're talking about? Where we're going to have our sisters who having oversight responsibility coming from the association that is headed by Madam Perpetual.
Great, that is where
to
I'm
work
coming.
in a good environment.
So once it has been uncapped, now you can pay realistic tariffs. So as I speak to you, together with the World Bank and all our expert groups, we are having our final meeting to review the tariffs so that we can begin to pay realistic tariffs. Some of the postures that these facilities take is mostly due to adaptation. If they don't have funds to run the facility from NHIA or NHIL, they are bound to charge, as this is a matter of survival. So now when you pay them the realistic tariffs, they can plan for all the overheads, administrative overheads, infrastructure maintenance, and also equipment replacement, all these. So this would, medium to long term, have a direct impact on service delivery and by extension on all the health workers who are within our facilities within this country.
Right. Dr. Jokoto is a great orator, but also does his work as well. So the thing is, by experience, we talk well. How do we actualize these into plans committee? And that's a question as media people, communicators, we tend to always ask. When we're doing the inquisition, how do we actualize or not only verbalize, but also actualize what the policy indicators are, committee?
Indeed, Roland, let's have the conversation here. Bright is still here with me. Bright, you are with NGOs in health. You work directly with the people in the health sector, the facilities. You've had the conversation so far. I heard you earlier when you were talking about the capping, that is 70-20. Explain to us what you meant by that.
Yeah, so I meant initially it was 75-25. And as it was being alluded by our honorable MP, it's 75 to the NHIL and then 25 to the capping. But we thought it was the reverse, and the 25% was, even though a huge money going into the NHIL. If you heard Dr. Jokoto well, now that it's uncapped, it's adding about additional 100% to that fund. If they were receiving about 4 billion in quantification at that time, and now it's getting to about 10 billion, then it's about multiple the fund already. So if the president has uncapped, it was a good news to all of us, meaning that NHIL is going to get more money.
Right.
That is giving them the energy to do the realistic tariffs he's talking about. And now we should be prioritizing what goes into health infrastructure. What is there for maintenance, what is there for equipment, what is there for personnel and all that. And these are the things we are looking out for. And even the introduction of the Ghana Medical Trust Fund is also additional funding that is coming to the sector to support rebound or reset the health agenda altogether. And this is what we are looking out for as civil society, to see that moving forward, health infrastructure in general is not a challenge. As we all look at seeing facilities look like RAGE, look like UG, University of Ghana Medical School and all that, then it means even down to the districts, our district level health facilities, those are the hotels we need to see. Because
district levels?
Yes. People at the district, if we start mentioning districts, Bungo and then other places, none of them are going to travel to see UGMC and then RAGE. So the facilities they'll be seeing there is their district hospital. Let me say that, yes, and apparently it's going to be the biggest referral facility when they are getting referral from the CHIP, the health centers to that side. That led to the introduction of the NOPs, the Network of Practice Program, so that we see that there are unique facilities that are interlinked with the other CHIPs and then the health centers, and their personnel, specialists who are delivering service. So when we even talk about access, we are not looking at physical access because we have the personnel who can deliver the services at that community level. So we are looking at NHIS with these resources together with other funds that might be coming in our research system to look at how we can get better facilities moving forward. Indeed,
Bright, I'm going to come back to you. We'll look at what prioritization looks like if the NHIS or NHIA gets all that money, where they should be putting it. You've mentioned the district levels, but what would it look like practically? Let's hand the microphone over to Dr. Olenu. Dr. Olenu, many of these facilities will fall under the Ghana Health Service. Even the staff too will fall under the Ghana Health Service. You deal directly with these people and the facilities. Why are some of them so bad?
Well, some of these facilities, sometimes we shouldn't forget about the human factor, because these facilities are managed by people. So why is it that sometimes you visit a private facility and everything seems to be doing well, but you come to a public facility, then our resources are not good? So it boils down to a lot of maintenance culture. And then we have to make sure that we have performance contracts with medical directors and facility managers, where the Director General of the Ghana Health Service is drawing performance contracts with the facility managers. He's expecting to see key performance indicators at quarterly visits to see if you are maintaining your equipment, if your wash facilities, everything is on point. Because you go to private facilities that provide some of these services and everything is going well, but you come to the public service, it seems like the maintenance culture. And also we shouldn't forget that the human resource is not equally distributed. Some have more human resource available than others. So we also need to have very equitable distribution of human resource so that we'll be able to address some of these key issues. So I think we shouldn't forget that the software components of the health system, people's values, their beliefs, and their attitudes towards maintaining things that have been entrusted in their care is very, very important if we have to maintain the state of our health facilities. Thank you.
I see. But this maintenance culture issue you mentioned, we know that there is a crossbreed between public sector workers, health workers, and then private sector health workers, which means that many of you who work in the public sector are the same people who work in the private sector, yet you keep things at the private sector better. Why is that a case?
Well, it's a very difficult one, but it's because, for example, let's assume a private person has invested so much money. So maybe should we say their supervision is more regular, or maybe they are very, they are ensuring that things are going very well. And also, you realize that maybe people are afraid to easily lose their job security. They are afraid to lose their jobs easily with private person, because a private person wants to make maximum amount of money or investments. They want returns for their investment. So they will ensure that things are running properly. But as I said again, it shouldn't make a difference if you are a professional, whether you are working in a public or a public space or private space. If you believe in the inherent worth of every human being, it doesn't matter where you see them, whether in a private facility or a public facility, the same level of care should be given across. So if you are maintaining equipment, if you are working hard in a private facility, you should do the same in a public facility, because people access care from different levels of the healthcare system, and they should receive equal care, equitable care, high quality care. So we should stop saying that our public, because you work in public, we can do what you like. Things are changing. The Director General is really on ensuring that our health facilities are functioning at the highest levels. Yeah.
Doc, I'll stay with you a little longer, because I know you have practiced locally, you know, prior to your appointment at the Ghana Health Service. Financing also means that you're unable to get the tools that you need. Poor financing, excuse me, also means that you're unable to get the tools that you need to work, the equipment that the hospital needs. In terms of the logistics of delivering health care, how bad is the situation for you as a practitioner?
Well, so as I said, it is variable. It's variable depending on where you find yourself. So we saw the Harmonized Health Facility report that was presented to us, realized that some places do have enough, some places do not have enough. And I mean, it's one of the gaps in our healthcare system. So that's why we are working towards equitable distribution. That's why we are working towards working with NHI to ensure that no matter where you are, you should have access to the basic, the minimum requirements, yes. So I think for me, it really behoves on the practitioners to take good care of whatever equipment they have, because you realize people come to public facilities, they complain about broken down equipment, and then they are referred to private facilities where they get their services done. So what is it that we are not doing right in the public, which means that we should change our attitude. We should be able to maintain our equipment, and then we should be made responsible. Facility managers should be made responsible for the maintenance of equipment in their facilities. Of course, we have budgetary deficits, but that doesn't mean the little we have, we shouldn't take care of them. Because you go to big hospitals, every now and then their machines are broken down, but the same private facilities are continuing to provide services. So maybe there's something we need to do, or something we need to learn from the private sector to implement in the public sector. Maybe it's hold people responsible, or make sure people are sort of not punished, but made to pay for mismanagement, because it's a cost to the nation and then it's a cost to the government. So we should take care of that here.
Indeed. When we come back here, we'll deal with the issue of accessibility and the quality that exists beyond the regional levels, beyond the national levels. I want to hand over now to Dr. Winfred Barr. He is the Registrar of the Health Facilities Regulatory Authority, HEFRA, indeed. And Doc will share with us what they have gathered so far on our health facilities. Doc.
Hello, thank you very much. So this morning we want to show you a few of the things we've gathered during our regular monitoring. I want to say that this is not a survey of all the health facilities in Ghana. Actually, just last week, the Honorable Minister of Health has asked me to do a survey of the state of all the health facilities in Ghana, starting with the government hospitals. So from next week, we are going to start that assignment. But earlier this year, we did a pilot study of some of the health facilities in Ghana. And then we concentrated on just the health centers and some chiefs compound. So I will take you through some of the findings. Just know that the higher levels are not part of this survey, and just so that we can tailor our discussions towards that. So we said we thank TV3 for this. So we have a legal mandate, the Act 829, the Part 1 of the Health Institutions and Facilities Act 2011. So we are supposed to register, inspect, license, and then monitor all health facilities in the country, both government health facilities and private health facilities. And this is key to achieving providing safe and quality health care in the country. So I will take you, just so that you understand what we are doing, I'll take you through the health facility types we have in the country. So we have what we call primary hospitals, we have secondary hospitals, tertiary, quaternary. Currently, we don't have any hospital in Ghana that has been licensed as quaternary yet. Then we have the chief's compound, the health center, infirmary, maternity homes, polyclinics. We have the general family medicine clinic. Then we have the laboratories. So for them, we also have laboratory diagnostic imaging. We have basic, primary, secondary, and tertiary. Then we have the specialist clinics like nephrology centers, cardiology, dispensing optician center, eye clinics, dental, psychiatric clinics, physiotherapy. We have the over-the-counter medicine shops, and then the pharmacies. These are the kind of facilities we regulate. So for the CHIPS compound, like we said, is the basic of our facilities in the healthcare delivery system. And they are very close to the people, especially in the rural areas. So for them, the minimum is a community health nurse, or an officer or a midwife. When you come to the health centers, so they are a bit more advanced than the CHIPS compound, there it has to be manned by, the minimum requirement is a physician assistant or a nurse practitioner. Then we have the general family, so from the general and family medicine clinic, we have the medical and dental practitioners in charge. All right, so then we have the polyclinic, primary hospitals, secondary hospitals, and then tertiary. For the tertiary, that's where we have our national and then the teaching hospitals. And there are just a few, about 6 facilities have been licensed as tertiary hospitals. So I heard somebody saying there are more. As far as we are concerned, we have licensed only 6 as that. And they must provide specialist diagnostic care, complex care. To qualify as quaternary, you must start having organ transplant and the rest. So I believe that hospitals like Kolebu, UGMC, and Konfanoshi can apply for that. So that's our 2025 snapshot. Now, these are CHIPS compounds and health centers. So we looked at 112 facilities, 60 in the Ashanti region and in 52 in the Eastern region. And it's a mix of CHIPS compound, health centers, maternity homes, and then clinics. Like I said, currently, from next week, we will look at all the facilities to teaching hospitals in Ghana, and then we will let you know. But yes, this is what we found. That only 17% had oxygen cylinders or concentrators available. Some of them have cylinders, but no flow, the kits and then the max. Then only 25% met minimum staffing equipment. And these are health centers and CHIPS compound. So most of them, you have only one nurse managing the whole place. And that can be. Only 17% of facilities had fire extinguishers in good working order. And that is dangerous because when there's a fire outbreak, it's not safe for the patients and the staff themselves.
FM 92.7.
Yes. 13.5% of facilities had functional resuscitation kits. And then 32.5% of facilities across both regions had functional patient washrooms, which is the rest, most of them are just makeshift washrooms, which are not very good. And then 40% of the facilities offer maternity services with complete delivery packs. They are supposed to have all of that. So I explained some of this, and so let me not go. And so let me show you some of the things we found. So you can see shafts. These are not supposed to be disposed in this way. We should have shaft boxes. But outside, so if somebody gets there, this is very dangerous. When you say shafts, what do you mean? You mean needles. The needles we use and the blades, yes. And you can see an incinerator for a health center. This shouldn't be. So this can even catch fire by itself. It's not safe. And look at some of them. So that's an exercise for records. But these are how some of the washrooms. Yes. So that's supposed to be a washroom for some of the facilities we inspected in the first quarter of this year.
Which area did you find this?
So we'll not be able to mention names now. But we are taking measures on that. We are taking actions. So you can see some of the washrooms. These are real. So, yes, you can see how dilapidated some of them are. Like, and look at some of the beds our people sleep on. So, some of the OPDs, you can see their structures are not looking very good. Storage facilities, treatment rooms are not up to standard. Look at some of the beds, treatment room.
3FM.
Which level facilities are we looking at?
So, like I said, we are looking at chiefs compounds.
Chiefs compounds.
And health facility, health centers.
Okay.
And these are mostly in the rural areas.
Where people need them the most?
Yes.
So with the poor Ghanaians, this is what you give us?
So this is what the state of healthcare in Ghana is. But I am sure that this current government is very poised to change the narrative. Infrastructure. So 46.5% of the facility did not have continuous supply of water. Some
Across
of them
Ghana?
Yes. And 65% of did not have functional washrooms. We've talked about that. Fire extinguishers, very basic, it must happen. Bushy surroundings, poor lighting and deteriorating buildings were observed. Electricity, 41% of them did not have constant electricity supply. We need to look at that. So we need some backup power supply for them. Most of them do not have. But I'll put this one there because I want you to see just basically what I've shared. But we've added some data from 2024 that will let you see that as the facility becomes bigger, so this is the list, becomes bigger, things get better. So when you look at staffing, as you move to district hospitals, regional hospitals, staffing gets better. But at the lower levels, we have great shortfalls of staffing. Like I said, we will bring the higher facilities in our next survey. All right. So focal persons, so like I said, some of them, just a single midwife handling a place where you should have about 5 nurses handling. Okay? So those were some of the gaps we noticed.
2.7.
59% lacked pharmacists. Some of them is the same nurses who dispense instead of getting technicians and the rest. Emergency preparedness, most of them do not have oxygen cylinders. All right.
All right. I think we have to put a... Yeah. So that also put the matters into perspective. And it's quite interesting. And Auntie Perpetua. Yes. Yeah. This is where you're... on our stream, I have Ajwa Sally, who says she currently is at a health facility, a CHIP compound. Yeah. And they don't have anything. You know, virtually, they have to double and do everything by themselves. And I have a medical doctor now. At the time he was a student, I met him in Beijing. Okay. All right. And he went to do his clinicals in the best Chinese hospitals. He currently is doing his post in Korea currently. Emmanuel Adepa Adapo is watching.
I don't think he'll come back.
He will. When he came, so for example, when he came from China, you know, we have this rift where there's a pushback from the medical, where it takes time. So he went to the upper regions of Ghana to go and sacrifice. He even used aboboya and some of those things to be able to practice. He got recognized and then got to reach. Okay. All right. But at the end of the day, all the top professionals want to be in Accra. Yeah. I think that's right. It's like the lawyers and everything. And then those who don't get lucky, they'll go to rural areas. And they are handicapped by way of resources. Your own people. Okay. So how do we intend, one, motivating them to be able to work in these conditions? And two, how do we make sure that we equip them by way of human resource-wise or practices or skills to be able to manage what they have?
Great. So, indeed, it's very disheartening when you look at what we've just seen. But the truth is that that is the reality on the ground. And just like we've indicated here, at the district facility level and the health centers and the CHIPs, that is where most of our people can actually access first-hand health services before they are referred anywhere else. And if you look at the state and the numbers that we showed, you see that for most of these facilities, it's one nurse, a community health nurse who is there, or a midwife, or somebody who is standing in for all other professionals. And indeed, if you go to the hardest places to reach, the underserved, the typical rural, the deprived, it's a nurse that you'll find there who is working. most of the other professions won't accept posting there because, one, look at the facilities we saw. Who wants to work in those facilities? And two, the social amenities there for educating your children and all those things, nothing is there. Who wants to accept posting there? So usually when the Ministry of Health and its agencies do the postings, especially for our cadre, it's very difficult for most of them to accept, pick their bags from the urban centers where they are and move to those areas to go and work. But at the end of the day, you want a job, you want to be paid monthly. So they take those decisions and move out there, go and rent homes that have, how do you call it? No, the worst of washrooms.
Not fit for purpose.
Not fit for purpose, but they go and live there just to provide services. Some have to cross rivers, wade through forest areas, ride bikes they've never ridden before, learn to ride them just to reach communities to provide services. So indeed, if we have these numbers there, helping to care for the populations that are there, then it's important that we care for them. We care for them by putting in incentives. We've talked about this rural incentive package for health professionals for a very long time. It has not seen the day of light. In fact, the light of day, sorry. The WHO funded a really crucial work that was done by the Ministry of Health to put these packages together for those who would want to serve in deprived or underserved or rural areas. All those categories were made, and it was a brilliant job. The packages were wonderful.
So they are in the book?
They are in the book. It's,
okay. So what are the packages?
Well, if you accepted to work in an underserved area and accommodation was to be provided for you, you were supposed to get a top-up in terms of your monthly remuneration. You were supposed to receive some support for educating your children, some transport allowance and all of that, plus a limited or a shortened period for further education, for your promotion and all of those things.
Why didn't you guys implement it alongside the policy implementation?
Well, Ghana Health Service is doing a bit of it in terms of promotion and promotion out of 10 and in terms of study leave and all those things. So it is there in a bit, but not in totality.
I see.
But we need to do more. We actually need to do more.
So you acknowledge you need to do more?
We are not in the position to provide, but we can advocate.
You were a medical doctor, Dr. Nawani.
Yes,
okay. So then you became a mainstream politician, MP.
Yes.
So you empathize with your kind.
Yeah, I worked with the Ghana Health Service. During that time, the Ministry of Health.
Yeah. Can I ask a question?
For 6-7 years, and I've been able to go private.
Great. Will I be right to say, when you are from practice and you come to the policy space,
yes,
and let's say the governance space,
yes,
you forget about your friends?
No, you don't forget about them.
Because you look very plush, and people in the rural areas who are also doctors like you and not MPs don't have their party.
I built an 80-bed capacity hospital before coming into the public space. And I also have a 40-bed capacity hospital at Wasekropong before coming to the public space. I operated a school before I came to the public space.
I understand that. I'm saying that...
I had a lot of things, actually, before
I'm not talking about your personal possessions.
Yes.
We're not doing asset declaration.
No, you said
I'm talking about pushing the policy towards its implementation stage, where you have seen practice clinically,
yes,
and then let's say health entrepreneurship, you are there as well.
Yeah.
And so I'm saying you know the real issues.
Yes.
Maybe for you and those who tend to manage policy, let's say at the governance level, why is it difficult to translate your own experiences to improve a sector?
And that is what I'm doing now. Honestly, it is the dissatisfaction with what I was seeing at the consulting room that moved me into this. Yes, because I realized that I couldn't provide for practically everybody who came there, had no money. You know, we had a policy that take care of the person before you even ask for money. That was the way we were able to establish ourselves in Dunkornofin. And after that, the patient would not be able to pay. And indeed, throughout my 25 years in private practice, I never sent anybody to court. Because when you see a person who cannot pay, you just know that this person even do not have the money to pay. And it is this issue that brought me out from the consulting room to this space that I find myself. And what I've realized is that, honestly speaking, first and foremost, we need to find a way of managing our staffs. What we are talking about, that when you come to Accra, you have got a lot of staff, you go to the rural areas, I mean, there's lack of staff and the rest. We need a tier of motivation. And to be able to do that, we need resources. And I'm saying that people, look, a medical doctor will agree to go to anywhere. The family is there, but he can leave his family in Accra and go. If only one, where he's going, his skill set is not going to diminish. In other words, if he's a surgeon, if he goes there, he should be able to do operations. You know, he should be able to carry out those diagnostics that will allow him to diagnose certain cases and be able to operate on them. That is the first thing. The second thing is extra income. And that's where I'm talking of the lack of managers at our hospitals. We lack healthcare managers at our hospital.
Okay. So in effect, you're saying that a medical professional should not necessarily translate to being a good administrator or manager?
Yes, you need further training. Back in Canada, for example, now, it appears if you don't even have an MBA